The following podcast is part of a certified educational activity titled 10 Steps for Highly Successful Myeloma Care Guidance on the Road to Remission with Antibodies, BCMA Immunotherapy, and Other Innovations. Access the entire activity and complete the post-test at peerview.com/FRR860. Downloadable slides and practice aids are also available.
Good morning, everybody. My name is Beth Feynman, and I am so pleased to be here today to share 10 steps for highly successful myeloma care. I'm joined today by my friends and colleagues, Donna Catamero from Mount Sinai and Charisse Gleason from Emory. So let's discuss the spectrum of multiple myeloma. So multiple myeloma is a cancer of the bone marrow plasma cells. They have a very important function in producing antibodies to protect us from getting sick. Unfortunately, there's one cell that turns malignant and continues to secrete, one clone of a normal cell continues to secrete a monoclonal protein. That protein can cause end organ damage. That protein can cause people to be very, very sick, or some people just have that protein due to the biology of their disease. There's 3 different phases I like to describe. The first is the monoclonal gammopathy of unknown significance. That's where you have a little extra protein in the blood or urine of your patient with monoclonal gammopathy, and we don't know how significant it is. Those patients still require monitoring, and so we check blood and urine tests about every 6 to 12 months. The second phase is smoldering myeloma. Now, those individuals have a little bit higher percentage of plasma cells in their bone marrow. If you were to do a bone marrow biopsy, they have a little bit more blood and urine protein. Those patients are watched a little bit more closely, depending on the level of protein in their body. And so right now, what we're trying to do is tease out those high-risk smoldering myelomas. Those will have an M spike of greater than 2 grams per deciliter, bone marrow plasma cell percentage of greater than 20%, and those individuals are more likely to require treatment. So that's where we're kind of putting them towards a well-designed clinical trial to really determine, should we start treating before they have organ damage or not? And then finally is the malignant stage. So you have the various stages of myeloma. Those patients have CRAB, hypercalcemia, renal insufficiency, anemia, and bone disease. And those are then further divided into high risk or standard risk categories, which we'll be discussing. So again, you have all these slides available for download. The content on this slide is just what labs, what bone marrow biopsy findings, and what radiologic imaging are we concerned about. So basically, it's putting all the pieces of the puzzle together. How much monoclonal protein and where is it located? Is it a light chain? Is it an intact M spike in the blood? Then we're going to look at the cells in the bone marrow. So there's the standard risk characteristics, but then the high risk is like a deletion 17p, gain or amplification of chromosome 1q, and some other translocations that are listed on the slide. And fortunately, if you have standard risk with the trisomies 1114 and then T614, those patients will do pretty well with very little therapy sometimes, but we still offer them a standard multi-drug approach. And then finally, radiologic imaging. We like to do more sensitive imaging, like a whole body low-dose CAT scan, a PET CT, if you're really, really worried about multiple myeloma. The olden days bone surveys are no longer considered good at detecting osteolytic bone disease. You can miss 25 to 40%. So if you have a low risk, MGUS, and you don't think they have bone disease, that might be okay in some centers, but it's really that sensitive imaging. So the next 2 slides will highlight an overview of nursing strategies for management of patients. These are key things that Charisse and Donna and I thought we should highlight, such as bone health. So when you have a patient with multiple myeloma that's requiring treatment, make sure that you're looking at their bone health. They're at risk for bone fractures, so we give bone-modifying drugs to minimize the risk of skeletal-related events. Make sure that they're on vitamin D and calcium. Involve the primary care team to help you with this as well. Infectious diseases, we're going to talk a lot about that later with BCMA and CAR-T, so I won't go over that. But really just the usual stuff. Wash your hands, avoid people with colds, up to date on immunizations as well. And GI toxicities with the standard treatment, sometimes you can get a lot of diarrhea and constipation, so keep in mind of those. The next slide highlights the neurologic, renal, and disease, etc. monitoring. This is kind of part of a care plan that I put forth in my notes when I see patients in the clinic. I want to always say, what's your neurologic status? Are you having peripheral neuropathy from bortezomib or from the disease itself? making sure to remind them not to take NSAIDs, IV contrast dyes, because the ionized contrast dye can be very hard on the kidneys. Disease monitoring should be on a monthly basis for most, and sometimes you can go a longer monitoring interval, but have that discussion with the care team and the patient and set expectations for how you're monitoring the disease, especially if they're high risk, they need more frequent monitoring. Health maintenance, we want to keep them fit for the next therapy, right? So exercise, stop smoking, don't start smoking, alcohol moderation, all that kind of stuff. And then a survivorship care plan. That's really a plan of what they've had, what we're going to plan on giving them so that they can take that with them. I'm so pleased to see that since 2015, we've had such progress with monoclonal antibodies. And those of you who know me know I started nursing care of myeloma in the 1990s as an inpatient nurse. And since then, we've seen an explosion of new therapies, and primarily since 2015 with the anti-CD38 monoclonal antibody, daratumumab, SLAM-F7 elotuzumab. We've had expanded indications. And then in the last 2 years specifically, CAR T-cell therapy and bispecifics, which we're going to go into great detail on. Now, despite this progress of these new, innovative, excellent therapies, this slide highlights, isn't it pretty? It highlights all the different ways that patients are using these drugs. And if I can draw you to the monoclonal antibodies, only 27 patients, which is 2%, that's the green one, started their front line with an anti-CD38. And there was an uneven switch. Even in the second line, patients in this analysis were not given monoclonal antibodies. And these CD38 monoclonal antibodies are very effective at inducing deep responses. And the idea is to get the disease burden as low as possible so they can stay in remission as long as possible. This is a slide that highlights real-world outcomes and a need to integrate modern therapy with triple-class exposed. That means they have like proteasome inhibitors and monoclonal antibodies and the IMiDs, like such lenalidomide and pomalidomide. What you're seeing here is that there's a poor prognosis that's conferred when you've had all exposure to these drugs. So this is an increasing need to give newer therapies because as this line drops down, people are doing worse. And so new drugs, that's what we're going to talk about. Now, this symposium is also sponsored by not only PeerView, but the HealthTree Foundation for Multiple Myeloma. And they have three main core components. So innovation that saves lives, they have patient education and navigation tools, lots and lots of programs that create patient connections and build the community, and a living real-world evidence data portal they can put information in that delivers researchers the data that they need to help improve outcomes. Also has innovation that educates. Think of that myeloma patient at home that doesn't necessarily want to go to a support group or whatever. There's 40 courses and 800 plus video lessons that they can take part in. And then we have innovation that connects. There's one-on-one help by experienced patients and caregivers, over 250 coaches, and lots of resources that are all free. I'd like to conclude my introductory session by saying that these are our goals for today. We're going to augment your knowledge of key evidence and guidelines supporting CD38 platform antibodies in myeloma, BCMA and non-BCMA, equip you with the skills you need to help plan the treatment for your patients and their caregivers, and then provide you with guidance for addressing practical aspects of care. And at this point, I'd like to turn it over to Cherise Gleason, who's going to walk then run principles.
Thank you, Beth.
Thank you.
All right. Thank you for joining us this morning. And so just to build on what Beth just showed you, those slides, I want you to think about the supportive care piece of it, because we're going to focus a lot today on the new drugs and our, sequencing and our regimens. But think of those supportive care things throughout the care continuum for your patients. So we're going to start off with the patient, Christine. She's a 66-year-old newly diagnosed symptomatic myeloma patient. So she has good functional status, 66, pretty young these days. Baseline findings, she's anemic, so that CRAB criteria. No other comorbidities. Her performance status is pretty good there. And she does have a 11-14 translocation in her marrow. But remember, that's a standard risk feature. We see that in about 16 to 24% of patients. And so no concerns with that. And so the first thing we do when a patient comes through, right, we want to decide, are they eligible for transplant or not? And remember, sometimes even if they're not eligible, they could be down the road, right? And it's not about age, it's about the patient sitting in front of you. So we're talking about this. What is she eligible? So we say, yes, she could do transplant. She's got a good caregiver. And so what do you think, Beth? And is she a candidate for a CD38 quad?
Yeah, absolutely. And Sharice, you're going to share some data to support that. But I had that one slide early on with all the pretty colors, and most people did not get up front the CD38. And we really think that this can deepen the responses. And MRD negativity, like getting rid of all those bad clones as best as possible, is super important. Donna?
Yeah, no, I think she's a great candidate for a quad. And my saying is that you get the benefit of 4 drugs with little added toxicity. The thing that I think we're concerned about is maybe an increased risk in infections. So there's a lot of education, what to do for patients. So really honing in on infection prevention.
Yeah. And our nurses really play a big role in that, right? So we meet with our patients, we talk about these regimens, but our nurses are who see these patients when they come in for treatment, so that ongoing assessment. So how do we think the nurses best can communicate those nuances, right? Because it's ongoing education and reinforcement with our patients. So, with the safety and logistics of it, Donna, how do you recommend the nurses?
Yeah, so like my main focus with the quad is, we're very familiar with the bortezomib toxicities, the lenalidomide toxicities, but the CD38, like I said, that increased risk of infection. So what you need to call us for, what, things I can do to help prevent infection. So I really think those are the key points when starting someone on a quad therapy.
Yeah. My key point is a calendar. So, right, so these patients don't know when to come in for their appointment. When do I get lab work? What am I looking for? So the first side of the calendar is weekly for 8 weeks, daratumumab if that's your CD38. You take the lenalidomide at bedtime. And then we do weekly bortezomib instead of the twice weekly that you do at Emory. And so different centers have different plans. But anyhow, so doing that calendar, and on the back of that calendar has watch out for neuropathy with bortezomib, watch out for infusion reactions with that. So that calendar is my answer.
And I would just remember on this newly diagnosed patient, that psychosocial piece, right? This is all new to them. They may not have ever even heard of multiple myeloma before. So, keep that in mind, and that ongoing reinforcement of the treatment, getting them through those first couple of cycles can be challenging. Beth mentioned MRD testing earlier. So MRD is looking for minimal residual disease. So when the patient is newly diagnosed with that first marrow, we want to send MRD. We want to do it when they have a high disease burden, so we can really look at the sequencing in their marrow. And it's with these newer drugs, as we're going to talk about, MRD has become so important, and one of the reasons why adding that 4th drug up front really makes a difference for our patients. So we would recommend that, yes, Christine get a CD38. She is fit, so she is eligible for transplant. Multi-drug regimens induce deeper responses, right? So we have all of our regular testing, and then MRD takes us deeper. It looks at 1 in a million cells to see if we can detect myeloma. And so what we found was when we throw these antibodies up front, we can drive that response deeper. In the old days, because we've all been doing this a long time, we didn't have these drugs, right? And so you held a drug back because you didn't want to give a patient everything. But that's not the thinking anymore. You give them the benefit of the treatments you have. You would never want to leave a drug on the table. Get that deeper response, because we know functionally there's a handful of patients we'll actually cure. The problem is, we know they're low risk, but we can't tell you which patients, because low risk can behave like high risk, as you'll see today. So we're going to look at some of these studies that got us here where we are. MRD is becoming very common, so it's something to talk to your patients about. And, be prepared to tell them why we do this and that depth of response and looking for that 1 in a million cell. So this is the NCCN guidelines on drugs for induction therapy. But I want to bring to your attention that VRD has been a standard of care for many years, 3 drugs, right? But the Griffin trial was a phase 2 trial that first looked at what happens if we add daratumumab to it up front. And some of us, at my institution at Emory, We actually changed our practice years ago based on that phase 2 trial by adding daratumumab up front because we saw better and deeper responses. I'm going to show you some of the newer data from the Perseus trial that was presented at our last ASH in December. Looking at, Perseus looked at, okay, phase 3, can we take standard of care therapy with VRd and make it better, so plus or minus daratumumab. This is the dosing of it, standard dosing, pretty much what you're accustomed to on that. And the endpoint was progression-free survival. And you can see by the curve how much better the patients are doing that receive daratumumab up front. 84.3% versus 67.7%. And adding DARA to the VRd regimen just improved the progression-free survival and also the MRD negativity. So we're checking those more often. And, the question about how often do we marrow patients, in these trials, you were marrying them more frequently to look at that MRD status. We probably vary a little bit in our practices on how we test MRD, but you're seeing it more. And right now, the technology is through a bone marrow biopsy. 64% of patients were able to discontinue the DARA portion of maintenance. So what was different about this study is it also had a consolidation and a maintenance, and the maintenance included the daratumumab, but if the patient was MRD negative, they could come off of it. And so I think that we all would agree with that antibody up front for that quad therapy. The maintenance setting, there's still a lot of discussion around that. So not automatically all going to the monoclonal antibody and maintenance. This is the review of daratumumab dosing. We went to subcutaneous dosing on this years ago, right? Because you see far less reactions. It's so much easier for the patient, less time in a chair for them. So I would say the majority of centers give this subcutaneous. And patients, it's very well tolerated. They're very sad when they come off a monoclonal antibody regimen. But the thing you need to keep in your mind is infection. When we add more drugs, that potential for infection and long-term antibody, CD38 antibody use. This is another clinical trial looking at the ASCIA trial that took KRD, so carfilzomib, lenalidomide, and dexamethasone. Same thing. Can we make it better when we add cetuximab, which is a different CD38 antibody? And you can look at the data. Their overall response rates were better, and again, proving that quad made a difference in that therapy. And what you also saw over time was continuing deepening responses with MRD. Another phase 3 trial, the GMMG, also added cetuximab to VRd, same kind of results. And you can see there with the response rate, 50.1% versus 35%. So we're making these responses better. Isatuximab is an IV drug. It's given 10 milligrams per kilogram every week for 4 weeks, followed by every 2 weeks until progression. Though on phase 3 trials, they are looking at giving it in a different form, the subcutaneous, that's delivered with an on-body delivery system. So that's what it looks like. It is a push, and it's delivered in 10 minutes. So more to come on that. Now we're going to talk a little bit about maintenance. What are the maintenance options for Christine, Beth?
I'll just say briefly, so since 2017, there was a meta-analysis. 3 studies were pulled together that said lenalidomide maintenance can keep people in remission longer, and this was done in Europe and 2 studies in the US. So that's our standard of care, is to stay on lenalidomide for maintenance. But now we have these quads, and then Cherise published about the Perseus study where they kept on DARA, VRd, and then they could stop the DARA after a while. And then the ISCIA trial with the isatuximab CD38, they had, if you had a high-risk cytogenetic abnormalities, which wasn't on that slide, if you had 2 more, you had better MRD negative rates. So do you need it up front? And then after transplant, can you stop it after a year or so? I'm not sure. So the maintenance options to discuss with Christine would be like, okay, standard of care is lenalidomide maintenance, your standard risk, but maybe there's a clinical trial. Donna, would you say?
No, the same lenalidomide maintenance has been the gold standard for years. So we would definitely offer her that. She's standard risk. So it would be a conversation on whether or not she would need to add on that CD38 in the maintenance setting.
Yeah. And our center for this at this point, and she had a good response to therapy, so we'll just throw that in too. We could do single agent lenalidomide, but a high risk patient, a little different, right? And we'll talk about that a little bit. So how do nurses prepare a patient for the discussion and the use of CD38 maintenance?
What's so nice is that they were already on it. So we say, okay, you did so great with this daratumumab or isatuximab up front. Let's talk about, especially if there's standard risk, we might have that discussion. Again, outside the context of a clinical trial, it's hard to get approved. These were clinical trials. That's why everybody was able to take it. But if they were saying, I'm high risk and I want to be on the best treatment, then I would say, you know what, we're going to go back on the weekly for 8 weeks, then every other week, then once a month. And it's actually kind of nice, right? They come in, they get their cookies, they see the nurses, it's an outing. And shingles prevention from an infection standpoint, get up to date on immunizations, especially after transplant as well.
Yeah, I agree. It eventually becomes a once a month infusion appointment. So patients live more or less back to their baseline, and just coming in once a month. And our institution ran out of cookies, so I don't know how often they really want to come in.
We have great snacks at our
So these are the NCCN guidelines on maintenance therapy, and you can see the preferred regimen has been lenalidomide. But what we've learned from our experience with treating patients, those high-risk patients needed more. And so the recommendation is a 2-drug maintenance. And sometimes you start them off with a little dex as well and dial it down. You don't keep people on dex forever. But that's really a proteasome inhibitor and an IMiD is really recommended in that maintenance setting for high risk. And we'll see, what the data is telling us about also adding a monoclonal antibody to that. So what if our patient was a little older, maybe a little frailer or a lot frailer, and we said, no, can't do transplant on this patient? So same cytogenetics, had the 11-14. What do we do with this patient? Do we give less? Or do we give the benefit of a quad? What do you think, Donna?
So I think the CD38 is important for patients. Surely the daratumumab, lenalidomide, dex, the Maya study, patients are doing extremely well on the triplet. But, I want to get 4 drugs for my patients. So we can titrate the dosing, the schedule for the patient. So who's in front of me and how can I best scale down that treatment so that the patient can get the benefit of all 4 drugs. So I might start a patient on a quad, but a light version.
Okay. I agree. They had a study, Betsy O'Donnell from Mass General, VRD light, which you had bortezomib, standard dose weekly, sub-Q, and then the lenalidomide, was a reduced dose, 15 milligrams, and then the dexamethasone was a reduced dose, I think 20 milligrams if you're over 75. And so that's the VRD regimen that we use at my institution. And then I would just add on the CD38, especially if she's a little bit more high risk. And that is, like Donna said, very well tolerated.
Yeah, I agree. And, we'll talk a little bit about the Maya trial as well. So I think you want to consider the patient who's in front of you. We always want to think of that, right? So age, fitness, and remember, a 50-year-old patient can come in such bad condition that you wouldn't transplant them. Maybe you'd get them an induction and then get them better and transplant them, but it's really looking at the patient in front of you. So 3 or 4 drug regimens could be considered for Christine, despite her age, and really reinforcing those supportive care issues and lower doses through it. And so Donna mentioned the Maya trial. We do this for our patients a lot at Emory, giving them daratumumab plus lenalidomide and dex. So a triplet still, that benefit, and patients do very well on that. The Alcyone trial showed a quadruplet. This is from Europe, and they have different access to drugs, but they took their standard of care BMP and added daratumumab to that up front and saw a superior response, and patients tolerated that well. So there is data to say that, yes, you can also treat this more frail patient with that quad as well. So I think, we're changing our practices, and that's what the myeloma centers do. We take this data that we learn from clinical trials and we change practice based on that. This is the understanding the dosing schedules for CD38 triplets. I'm not going to spend a lot of time on this, but our nurses do spend a lot of time with this, and patients and calendars and getting them through. Just want to mention the IMROZ trial, which did take a CD38 quad option in upfront. So looking at isatuximab with VRd. So again, giving that VRd at that lighter schedule and adding that that CD38 antibody up front. And the primary endpoint was met, and it did show significantly improved progression-free survival when you added that up front for these patients. So you don't want to think older and less. You just want to modify those doses and give them the benefit of that regimen. And again, this is the schema for...
Why calendars are important.
This is why calendars are important, and I'm certainly not going to read through this for you, but you can see the scheduling for that. And so, Christine now, we're back to the 66-year-old Christine. So she went through VRd. So this is a different scenario, right? So many of us have already adapted that, adding that quad up front, but we still see patients come in who got the 3-drug regimen because it's been standard of care for a very long time. And so this patient, she got VRd up front, 4 cycles followed by autologous transplant, and then lenalidomide maintenance. But 13 months later, she's progressing. So by all means, she was standard risk. But now her disease is telling us, this is a very sounding high-risk profile. That's early to be relapsing. And so would we consider her refractory to lenalidomide? That's an easy yes. I think we all can answer that. Is this that point that you should recheck disease status? What do you think, Beth?
Yeah, absolutely. She had a standard FISH. She should have gotten 3 to 5 years out of transplant on len maintenance, but she didn't, and why? We don't know. So are there abnormal clones that were not detected at diagnosis, that are hiding around in the bone marrow environment? So I would say, you know what, maybe you're a good candidate for a well-designed clinical trial, and we have some available, or they can even reach out to HealthTree Foundation, has lots of resources as well for finding clinical trials and talking it through. But yes, I would recheck her cytogenetics. I would restage her with those labs, that same little slide I said in the beginning, as well as imaging, because she has this new soft tissue mass. Is she have disease anywhere else? Donna?
Yeah, like you said, Beth, the reason that she relapsed 13 months after transplant is really concerning. We really would like 4 to 5 years after transplant. So she's acting like a high risk. So we need to restage and find out what's going on.
Yeah, and we might not find anything in that parallel.
We might not, right? Myeloma can change, but we do know that she has a mass and a rise in her free light chain. And so I think there was a question in there about how often then do you marrow? And this is a perfect time to do that. So you're restaging them. You want to get new imaging, and whatever your institution does, whether it's a PET or a whole body CT or MRI, and get that bone marrow biopsy, because something is different in those genetics on that. So, I think this patient, again, good status. How can nurses help explain the next steps? And would a CD38 be a good option for this patient? Remember, she only had that 3-drug regimen so far. And if you look at lines of therapy, so she had VRd, transplant, and then lenalidomide maintenance. That is 1 line of therapy. And so if we're considering a clinical trial or our next treatment option, this is line 2 at this point.
Yeah, so if we did a bone marrow, she maybe had a gain of 1Q now. So that would be important because there's data to support the use of isatuximab as the next anti-CD38, which is available on the Isa-Pom Dex-Icaria and Isa-Carfilzomib Dex based on the ACCME trial. Interestingly, the translocation 1114, there's also clinical trials ongoing with lisafticlax, which is a BCL2 inhibitor. So maybe she would be a candidate for clinical trial.
Yep. Anything to add to that?
Yeah, no, she definitely could benefit from a monoclonal antibody since she did not get it up front. And, now that she's deemed to be officially high risk.
Yeah. And, there are lots of treatment options. You're going to want to get that antibody on there, and whether you give it with an immunomodulatory agent or a proteasome inhibitor, and probably, we might all say something different, but yeah, they are similar regimens. And these are the NCCN guidelines in that relapse setting. And you can see daratumumab, pomalidomide, dexamethasone falls into that, as do lots of other things. So, it's that, what are you going to partner it with? And there are options for that, or considering a clinical trial. So, Beth already mentioned, that in the ACCME trial, adding isatuximab to carfilzomib and dexamethasone did show that impressive performance-free survival, especially in those patients who have that 1Q gain. So that was nice about that trial, because we don't always look at the high risk in that. And so if you think of high risk, right, patient who relapses within 2 years of their initial therapy and transplant, relapse within 18 months for the patient who's non-transplant based treatment, gaining a new high-risk feature, so that 1Q or 17p deletion, or having extramedullary disease at relapse. So all those things tell us this patient's disease is more aggressive now. Looking quickly to the hypersensitivity reactions with antibodies in myeloma, you've got the IV daratumumab, half of patients reacted to that. We just don't give it that way anymore. We give it subcutaneous, and then the IV is isatuximab. You give these pre-meds when you start these drugs, but then from a nursing standpoint, remember, sometimes we forget to dial them back. So if you got a patient on cycle 6 of therapy and they're still getting 50 of Benadryl, reach out to the team. Say, please, they're still got these pre-meds. They don't need them forever. It's just initially with those early, that some people do it first cycle, some the first couple of doses, and then you dial those back. Hit them higher with steroids as well early on, and then bring them back. So something to keep in mind, so nursing principles with CD38 antibodies, you want to make sure they're on an antiviral, whether they've had a zoster vaccine, so Shingrix does not let them come off of their antiviral. The pre-meds that we just mentioned, they, get those pre-meds, and then we do need to dial them back, more aggressive when we start. Before you start a patient on a CD38 antibody, you need to send a blood sample. I know we have it for type and screen. We have it right on our orders, so it's not missed. But antibodies can interfere with your blood typing, so that way your blood bank has that sample. It also can interfere with your myeloma testing. These are IgG antibodies, and so you can see this circulating. If you look at immunofixation and you see, circulating daratumumab, that's why. You also want to check for hepatitis serologies, and then check every 6 months. And then treat infections aggressively. So these patients are at high risk for infection, and you really want to monitor them throughout. So I'm going to turn it over to Donna.
So let's start off with my first case. So Mark is a 72-year-old gentleman, and he's progressing after his first line of therapy, which was bortezomib, lenalidomide, and dex, followed by transplant, followed by lenalidomide maintenance. ISS staging 2 has a good performance status, but after 10 months of len maintenance, he's starting to have an early biochemical progression again, maybe a little high risk. So same question, and I think we already know the answer. Any restaging needed?
Yeah.
Yes.
Yeah. Bone marrow biopsy, labs, and imaging.
Yep. And, maybe I couldn't ask you this question last month, but is this patient CAR T eligible for his next line of treatment?
Yes.
Yeah. So hot off the presses.
Yeah.
Literally a few days ago, we are now moving CAR T up into the very early lines. But when is it time to start planning? Because historically, we knew that CAR T was approved in those later lines. So after 4 prior lines of therapy, and we always say refer early. But now if we have CAR T approvals for earlier lines, when is the appropriate time to refer that patient? How are your practices changing? Again, this is literally a few days old.
Yeah, he had a stem cell transplant after a 3-drug induction regimen, and then our maintenance, and he should have probably done well, just like Christine, but not all high-risk people do poorly and not all standard risk people do well. And so I would say this is an opportunity at the transplant center. So when you go to Mount Sinai or Emory or whatever institution, you can start talking about this is a possible option as well as clinical trials that they might be a candidate for.
Yeah, new data, right? And so I think we're all trying to figure this piece out too, but this is something that you would want to consider earlier, at least bring up when you're thinking about next lines of treatment. It's something else to think about.
Yeah, and I think we have to change the way we're thinking now. Maybe at the time of diagnosis, this is something we consider, because you always have to be a few steps ahead with myeloma, plan out your next 3 treatments.
Yeah.
So we decided to go forward with CAR T planning, and since he's relapsing, we want to start that treatment. So we're going to bridge him with daratumumab, pomalidomide, and dexamethasone. So assuming a bridging regimen with the CD38 is planned, how should nurses counsel patients on the purpose of bridging and then subsequent the CAR T journey? So Charisse?
Yeah, you want to get disease under control. So they need a new therapy. So they're progressing, but you need to get them on something, get that disease control, and you can start the process for CAR T. Now, the question comes up, if they're responding beautifully to their new treatment, do we push CAR T down a little bit? Do we move forward? It's a good time to go ahead as well.
Yeah, and you want to think of something that's not going to get them so sick that they can't get their cells back. And Don will go through the process of CAR T, but there's a lot of steps in it. And so we want to protect our patients the best as possible and set expectations for how long it might take.
So, we know now that Mark, as of this month, is a clear candidate for CAR T. So again, it's changing our mindsets now. We have to really plan early and those early referrals. And I think the good opportunity is, some of our patients are going to be transplant eligible, but some are not. So really just at that time of diagnosis, thinking ahead and maybe making those referrals and that communication between the centers. So finding out where your CAR T centers are. They might not always be at the transplant center, but more and more centers are becoming CAR T centers. So making that relationship early on, and then bridging strategies, because, and I'll show you in some of the studies, you want to look at the patient in front of you, and the goal is to get that patient to their cell infusion. So how do we optimize the therapy so I can get that patient to actually receive his cells? So, what is this CAR T journey? So, CAR T is a very unique MOA. So we're taking the patient's own T cells, we're genetically re-engineering them. So we're manufacturing the patient's T cells to target an antigen receptor on the myeloma cell. So this manufacturing process ideally would take up to 4 weeks, but sometimes we do see delays, so 4 to 6 weeks. And then those cells will get reinfused back into the patient, and essentially the patient has a living drug. And it's a one-time infusion, and those patients can stay off therapy for prolonged periods of time. Currently, we have 2 cell T products, and again, as of this month, they're available in earlier lines. So ide-cel, we can use as early as up to 2 prior lines of therapy, and we're triple class exposed. Cilta-cel, 1 prior line of therapy, and need to be lenalidomide refractory. So with our patient example, he was relapsing while taking the lenalidomide. So the CARTITUDE-4 studies, which led to the FDA approval of early lines. So the CARTITUDE-4 was patients with 1, 2, 3 prior lines of therapy. And you can see here with these curves, the cilta-cel arm did drastically better. But I do want to point out with my look at the lines, they do cross. At week 8 is when they got their cell infusion. So these patients did not make it to their cell infusion. So that just brings home the message of adequate bridging therapy. So there's no standard of this is what we always use for bridging therapy. You really need to look at the patient, what they've responded to, because we want that disease control so that we can get the patient to their cell infusion. This blue line is the patients that were randomized to receive cilta-cel. And you can see here, up until they got their cell infusion, their progression-free survival actually was worse. And this could be because of inadequate bridging therapies.
You didn't pick the right drug.
Yeah.
So they did worse in that first 8 weeks.
Yeah.
They got their cells back.
Yep.
That's why we've taken less of on us to figure this stuff out.
Right. And so the study dictated what bridging regimens we needed to use. But in real life, we need to pick the best regimen for the patient so they can make it to their cells, because we see once they get their cells, they have drastically better outcomes. And then not only drastically better outcomes, but improved quality of life. And you can see those patients who did receive the cilta-cel had a meaningful or improved quality of life compared to the standard of care arm. So the KarMMa-3 trial is looking at ide-cel in earlier lines. So this was in patients with 2 to 4 prior lines of regimen. And again, we see patients doing so much better than the standard of care, so those patients getting the CAR T therapies. So I really want to just bring home the message that the bridging regimen is really crucial to get your patient to that cell infusion. And then I just want to ask, like, Beth and Charisse, like, what do you do for bridging? $1 million question yet again.
So we heard from Donna how important it is to pick the right regimen. Now we have a drug called selinexor. It's an oral selective inhibitor of nuclear export protein. Say that 5 times fast at 6 in the morning. But it's a pill that they can take weekly. And in the earlier trials, there were a lot of toxicities. People had hyponatremia, weight loss, thrombocytopenia as a doublet with just dexamethasone. But now when it's given with bortezomib, or even in the phase 2 studies in the STOMP trial, we see that it's extremely well tolerated. And what's cool is that there's emerging information that it can enhance, it doesn't hurt the T cells, and it can actually make them more fit. And we want the T cells to be fit because we're programming them to be fighters. So in my institution, we might say, you know what? We want to give them that CD38 because we want to get them to the CAR T cell, but should we be giving selinexor in between while we're waiting for the cells to be manufacturing, or do you go back to what got them into response?
And I would just add that this is a different scenario because it's early, right? What we experienced on the clinical trials, these patients were heavily pre-treated. So you were putting together something to try to give them a benefit. On the trials, they couldn't get a new drug. So you had to put together a regimen of something they've received. And so I think we are all going to see differences, and you're going to see selinexor used a little bit more in this scenario, especially this early.
Yeah, and I want to stress too that bridging needs to be individualized to the patient. And then we also learned from our earlier experiences that bridging can actually decrease some of the potential side effects we see from CAR T, in particular neurotoxicity. So we did see a lot of neurotoxicity early on, and really those patients either didn't get any bridging chemotherapy or not effective, because again, a lot of these earlier trials restricted us on what we could give patients for bridging. But we know now that a good bridging regimen can decrease some of those neurotoxicities that we see. So now we're going to take Mark and change the scenario a little bit. So let's say he's a little bit older, 77. Now he's progressing after 4 prior lines of therapy, but he still has a good performance status. So you can see his treatment history here. He has several lines of therapy. So, how do we now counsel? So he's relapsing, unfortunately. But so how do we counsel Mark for the next step? And how do we counsel against some of these expected toxicities that we see with CAR Ts, such as CRS and ICANS? Beth?
Well, I think you're going to go into great detail about the CRS and ICANS, but again, the cytokine release syndrome occurs when, I feel like the cells all explode. There's a storm of the IL-6 and all these other factors that make people feel really sick. It's like when you get a flu shot, you feel a little achy, but way worse. And so that can occur with or without the ICANS, and I think Donna's going to go into that. But I would reassure my patients, we know how to mitigate these by getting you in good remission, and we know how to treat them if they occur, and we'll be monitoring you closely. So just reassurance for sure.
Yeah, I tell patients, right, this is like the worst flu-y symptoms you've had, right? Because that's something they can relate to. So fevers, and then we talk a little bit about those potential for neurotoxicities. This is a time with counseling too. Patient, You're not going to be able to drive for 8 weeks. You need to make sure that you have a care partner with you. And so bringing you in, for your visits and that, because we see them pretty frequently early on.
And then, Charisse, because I know we don't all live by a CAR T center, what resources do you, and I know Emory is the hub, so you have patients coming in from all around.
Yeah.
What resources do you share with your patients to help them with logistical challenges?
Yeah, I mean, we will use our other sites as well if we don't need to see them, or they're referring, right? A referring team can check labs for you, but you just really want to educate them on the things to look out for, when to call you, and when to get in.
Good communication between the center that they're starting at, because you have to hold therapy for 2 weeks in between the bridging.
Yeah.
And the HealthTree has lots of great resources on their website, and there's coaching and all kinds of. So I point them to the Leukemia Lymphoma Society, American Cancer Society. HealthTree is great with resources as well.
We let our referring sometimes do the bridging therapy as well.
Yeah, absolutely, because these patients are coming from a distance. So, I think we're very familiar, or we will be after I go through it, of the short-term toxicities, but the longer-term safety things that we need to consider. Charisse?
I think of infection.
Yeah, infection.
Lots of talk about infection, and that they're severely immunocompromised for a period of time, a long time after, more than what we've seen, with our other regimens. So starting those supportive therapies, IVIG, you get it going early, making sure they're on the appropriate prophylaxis, for antiviral, PJP prophylaxis, those kind of things, and that they'll be on them for a while.
I educate patients about why they're so low. So myeloma is a cancer of the plasma cells that are meant to protect you by secreting proteins. And now we're wiping those out with these BCMA-directed CAR T-cell therapies, so they not only have this functional hypogammaglobulinemia where their immunoglobulins are low anyhow, we're making them even more dysfunctional. So long-term infection risk has to be discussed.
And, that education prior to CAR T, we talk about CRS. It's manageable, relating it to, it might be like getting a flu shot and feeling achy and low-grade fever. But, we intervene early. We don't want it to get to a grade 3, 4 CRS. Neurotoxicity is rare, but that's why patients are in a setting where we monitor them closely. So the NCC guidelines, not quite updated, as, again, these earlier approvals were literally a few days ago. So you'll still see the CAR T therapies for 4 prior lines of therapy, and Beth will talk about the bispecifics.
Can't wait.
So just looking at, zooming in to that CAR T journey. So we talked about collecting those cells, manufacturing them, and then that bridging chemotherapy while we're waiting for those cells to be manufactured. So when we have those cells on site, the patients will be off their bridging. We'll start their lymphodepleting chemotherapy of fludarabine and Cytoxan or cyclophosphamide. And the goal of that therapy is to kill off their T cells to make room for the new cells that we're giving them. The first several days are typically going to be in an inpatient setting. I know there are a few institutions that are doing CAR T outpatient, but we're really monitoring those patients very closely for their CRS symptoms. And then that first 30 days, they're staying close by to the CAR T center so we can monitor for acute toxicities. And then when those patients go back into the community, we have to be mindful that they're at higher risk, hypogamma and cytopenias, and always infections. And then we can see here with the ide-cel, cilta-cel, the safety data. CRS is common, so we need to anticipate it, but it can be predictable depending on the product we're using. Ide-cel, we see it quick onset of CRS. Cilta-cel is a little more delayed. And then you can see the ICANS here, but again, I think the real world data is that with effective bridging, we're seeing less of these neurotoxicity ICAN events. So what is CRS? The hallmark signs of CRS is fever. That would be your grade 1, but it can progress to hypotension and hypoxia. In addition to, the cytokine release can affect every body system. So the goal is to identify CRS early and intervene. So at my institution with a grade 1 CRS, we're giving tocilizumab right away with acetaminophen. If there's no improvement, we'll consider adding steroids. So we're really trying to minimize the CRS grade to a grade 1. Neurotoxicity, and this can happen at any time. Typically, it's going to happen after a CRS event, but it can happen before or during. So, it has the gamut of symptoms. So from confusion to hallucinations to tremors. But typically what I see is it's often going to be confusion. I did have a patient with hallucinations, and this is why a caregiver is so important, is really required, because this can happen, like I said, delayed, patients already at home, and you can have, I was having a normal conversation with a patient, and then she asked me why there were purple pumpkins growing in the corner of her room, and, so you wouldn't know. So we really need to have that caregiver on board, but typically it might be some confusion, but also we see changes in a patient's handwriting. So we're doing our assessments every day, every shift, and you might start seeing drastic changes in a patient's handwriting, literally from one shift to the next. Neurotoxicity is manageable. We manage with steroids, but it's going to be institutional driven, and these things are reversible. So I promise you, your patients will not be seeing purple pumpkins for the rest of their life. But some key points. So referral early, regardless of what line you want to use it, always think ahead. We want to avoid steroids immediately after or before the CAR T therapies, because this can affect the CAR T. Bridging is key. We really want to individualize the bridging to the patient, and then infection, because these two CAR T therapies are directed at BCMA, and we see a high risk of infection, especially that first year post-CAR T. They're going to become hypogamma, and we're going to need to initiate IVIG. In my institution, we start IVIG at the time of lymphodepleting chemotherapy, because that IgG drop is drastic and quick. We're going to keep some prophylaxis. So here are the guidelines. You have the slides. There's a lot of guidelines here, but we really need to really look at PJP prophylaxis. We're monitoring CMV. We're monitoring CD4 counts, and really doing our interventions, immunizations, COVID, flu, yearly, and then we revaccinate after 3 months into a year. So because they're at high risk for mortality from infection, you really need to be on top of this. So with that, I'm going to pass the torch over.
And I'm going to try to be quick on my next section, because we have so many amazing questions coming in. So we want to get to some of that. I'm going to highlight some successful steps for the off-the-shelf BCMA. Off-the-shelf means I can write a prescription. We don't have to manufacture anything, and we can give it to the patient that needs it. We're going to talk about Thomas. He has high-risk multiple myeloma, relapse refractory. He is now 77 years old with a performance status of 2, which means he's 0 means you have no problems in your health. 1, you're a little tired and, maybe sitting in the chair a little bit more. 2 is a little bit more symptomatic from your disease. Now, is it from the disease itself, or is it from other comorbid conditions like COPD and all that other stuff? So we're looking at that patient and trying to tailor therapy to him. So he does have the 1q amplification and deletion 17p. So he's got what's called a double hit myeloma. He had a CD38, RVD, then transplant, then R maintenance. That's the 1 line of therapy. Then he had Darapomdex, his 2nd line of therapy, got about 11 months remission out of that. And then the 3rd line of therapy was carfilzomib, cyclophosphamide, and dexamethasone. He had some response at only 4 months remission. So this poor guy, the remissions are getting shorter as we go along. So his 4th line of therapy was selinexor or bortezomib dex. He just couldn't stay in remission long enough to manufacture his CAR T cells and get them back. So how would you counsel Thomas, Charisse?
Yeah, this is somebody who's rapidly progressing. So, Donna just explained the process of CAR T. This patient doesn't have that time to wait. And considering a treatment that's off the shelf makes sense to me, right? And I think going to a bispecific, which you can easily do and get them started, the next week.
Yeah.
Yeah, and if you can't get the patient to a CAR T now, put them on a bispecific, they might be eligible for a CAR T later.
Which one would you pick? We'll talk about
unbiased.
So there's the different targets. We'll talk about the BCMA targets, which is BCMA CAR T. So and then there's also the GPRC5D, talquetamab, and others in clinical development. So what are some of the step-up and subsequent dosing considerations to convey? Like, what do you tell your patients? Now, you do it outpatient in Emory, right?
We do. We do all of our bispecifics now outpatient. We initially did them inpatient, but we have a 24-hour urgent care center for our oncology patients. And so you do talk to them. There's a ramp-up dosing, right? They start with a low dose, and then you step up, and then they get a full dose, and then the cycle starts that following week. So you do talk them through that, what to expect, that they do need somebody to bring them to those appointments. You talk about the risk for CRS and ICANS. We do something a little different at our center, too, is we prophylax with TOSI, and which is a little different. And so looking at our data, we've actually moved it because you see very little, really. It's a grade 1. And we give it with the first dose.
Yeah, we're not quite at my institution, not quite there for the outpatient administration. But we'll step up in a hospital setting. But then after they get their first full dose, we can then bring the patients back to the community and they can receive these therapies locally.
Absolutely.
Yep.
And then what about infection risk? We saw that graph and the guidelines that Donna presented with lots of words on the slides. It said, bacterial, fungal, etc. Do we worry about that with the bispecifics too?
Always.
Yeah. And so again, we're smashing out the plasma cell, which is supposed to protect us, and with BCMA is that target. So you really get the opportunistic infections that you don't see in other areas. So Thomas might not ever get to a CAR T, so using a bispecific is reasonable. There's 2 FDA-approved bispecifics, the elranatamab and the teclistamab, and then there's a GPRC5D talquetamab, and that's important because if he was going to CAR T, we might say maybe we'll give him talquetamab, different target than his BCMA CAR T would be. But age is not a number for bispecific. Age is really not a number for CAR T, but you have to have a caregiver. You have to have time to manufacture the cells, and he does not have the luxury of time right now. Coordination of care is critical. So if he is that sick, he's probably at a referral center by now. He's had a lot of lines of therapy over a short period of time. And if you're a nurse that's caring for him, give him permission to say, you know what, we have a great center down the street. It's maybe, 45-minute drive, and there's resources available sometimes for transportation. He's a perfect candidate for a clinical trial. Maybe he would be a candidate for something good with a new agent. And then atypical infection is a major concern with the bispecifics and the CAR T cell therapies, which we'll talk about. So what are bispecific antibodies? So it's really kind of a neat theory, and I keep thinking this is like science fiction, right? Because we're literally engineering your cells, and it's like a helping hand. You have this BCMA target and then the CD3 target, and like a helping hand, it pulls it together to cause cell death. We have the teclistamab binding to CD3 and BCMA, and then the talquetamab is CD3 and this GPRC5D. So with that helping hand, it gets pulled together and causes a T cell activation, the cytokine release, and then causes the cell death. Elranatamab, you can see in the middle of the slide, is a humanized bispecific antibody also targeting CD3. And you can see the picture of the CD3 that grabs onto the cell over here, and then it causes tumor killing. And so the CAR T is kind of like Cherie said, a living drug where you do it kind of once after engineering the T cells. But with these drugs, you give it ongoing in different schedules. So the therapies for late relapses greater than 3 prior therapies, the bispecific antibodies are listed here on the slide, as you can see here, the different ones. As far as the studies that support the use for teclistamab, that would be Majestic 1, and there's lots of Majestic studies out there, but the Majestic 1 was the pivotal trial that gained the FDA approval. You can see, we talked earlier on, that when you get more and more lines of therapy, people are not responding, and it confers a poor prognosis, which suggests we need more drugs for our patients. And the overall response rate in this was 63%. So somebody like Thomas, who's had lots of prior therapies, he still can respond to the BCMA therapy. In this step-up dosing, and I like calendars, and so we give our patients calendars. Now, this slide has what's recommended days 1, 4, and 7 for teclistamab step-up. As Donna mentioned, she does it in the inpatient side, that you give a baby dose and then a little higher dose and then the full dose. So you can see the doses over here, 0.6 milligrams per kilogram, 0.3, and then 1.5. So that's your first full treatment dose. The risk of cytokine release syndrome and ICANS is super low after this. So that's when Charisse mentioned you can go back to your community or go to the outpatient dosing schedule, and that would be weekly. Now, you can decrease the frequency of dosing to like every other week after they've had a nice response, that 1.5 milligram per kilogram every 2 weeks after about 6 months is what it's recommended. In terms of safety, we already underscored the infection risk. So respiratory is the big one because the B cells are protect you against, IgG kappa is super important with gram-positive encapsulated organisms, so sinus and respiratory and ear infections. So highlight with your patients the importance of infection protection and reporting them frequently. It's hard because we still have this COVID thing and influenzas going around. And so sometimes they get sick of calling us, but tell them it's still important to do so. In terms of cytokine release syndrome, only 0.6% of the cytokine release syndromes were grade 3. Remember, 1 is really just a fever and hypoxia, and we give tocilizumab plus or minus steroids per your institution. Everybody's a little bit different, but overall it was mild. The magnetism MM3 study was elranatamab. Again, BCMA directed, the BCMA, CD3, host the cells. The take-homes after the 15.9-month follow-up on 123 patients, again, still a nice overall response rate for people like Thomas. Again, BCMA directed, we worry about the infections, but if they could have had in the study prior BCMA therapy, we had a belantamab mafodotin, which hopefully will come back. It was approved and then unapproved, and that's an off-the-shelf ADC, but it's something that will hopefully come back. Again, step-up dosing, this is day 1, 4, and 8 for the elranatamab. A little bit different baby doses, 12, 32 to 76 is the standard first treatment dose. So again, making a calendar and letting them know what to expect. You don't have to go into great detail. I just say, we're going to give you slow and increase the doses. When you go to the weekly, then you can go to every 2 weeks thereafter on subsequent treatment doses. Does this slide look similar to the other one? Because they are very similar. And I feel like when we talk about the overall incidence of these grades, you can say, well, maybe it's a little less likely to cause CRS and infections. But at the end of the day, we just really don't know. I think the take-home point, if you're thinking CAR T, you're thinking BCMA, infection, CRS, and ICANS. ICANS, though, is a lot less common in bispecifics than it is for CAR T. So what if he had received prior BCMA therapy? We did see on the studies that the elranatamab study, they could have had prior BCMA therapy. We talked about a little bit sequencing, though. So, Donna, can you tell me what you would do in your institution?
So for sequencing purposes, I would want to take a target, like the ultimate goal, 72 performance status of 77, performance status of 2. I would
Maybe more frail.
Yeah, a little more frail. I think bispecific would be good for him, but if he's a performance status 2 now, maybe, once we start treating him, it might improve. So my goal, I think, is still maybe try to get him to CAR T and maybe choose a different target. So let me try talquetamab, which targets GPRC5D, get him to eventually get to a CAR T.
Yeah. Any thoughts?
Well, I mean, that's the question, right? Sequencing and how do we do this? But you do want a different target, right? If you still want to consider that benefit of a BCMA.
Yeah, and I think about like lenalidomide refractory. So if you're progressing on lenalidomide, like for maintenance, for example, then you wouldn't go back to lenalidomide. And that's kind of how I think of BCMA. Now, let's say he had a CAR T-cell therapy with BCMA and he was in remission for 2 years and now he's progressing. Did those T-cell CARs just kind of like become tired and stop working? Maybe he'll respond to BCMA again. That's more likely the scenario where we would go BCMA to BCMA. But in general, I agree, changing to GPRC5D. Now, if we can't manufacture cells, he doesn't have a caregiver because he lives in Oklahoma and his kids live in Iowa, then that might be a different discussion. He's never going to have a CAR T, so just picking a BCMA now and then maybe a talquetamab later might be it. Assuming that talquetamab is an option, what are the unique things that you would share, Donna? Donna was like the queen of talquetamab. She had 2 posters at Greece meeting last year on managing side effects. What are some of the unique side effects you see?
So I think it's all target driven. So we see a lot of on target, off tumor side effects. GPRC expressed on myeloma cells, but also expressed on keratinized cells. So think tongue, skin, nails, and assume that it will happen. So a high frequency of these side effects in these patients, and really set the expectations. Management, I think we're good at managing the skin and the skin toxicities. Oral toxicities have been challenging, but setting expectations because patients do very well on these therapies.
Lots of taste changes.
Yeah.
So I think that we'll talk about those later on. So talquetamab, as I mentioned, is a GPRC5D times CD3 bispecific. Again, different helping hands, different targets slightly on the cell, so different response rates and different side effects. Like Donna mentioned, it has a lot of off-tumor effects, which means, again, it's on the skin cells. So they lose their taste and then they can lose weight. And so like if Thomas, for example, was like really, really thin from his disease progression, his cumulative disease burden, then maybe I wouldn't choose a talquetamab for him in this situation. It's finding the right drug at the right dose for the right patient at about the right time. And what did these ladies say? It's about the patient in front of you, too. We use data to inform our decisions, but we also have to use our noggin to see what's logical. So we see deep and durable responses in patients that have been exposed to that BCMA. So if he had a BCMA for whatever reason, we can see that he has prior BCMA CAR T, 72.9% had a nice response. Bispecific antibodies beforehand, a little bit less. So you don't want to necessarily go to a bispecific to, from a CAR T to a bispecific if you can avoid it, but you can still see nice response rates. In terms of the step-up dosing schedule, days 1, 4, and 7, again, baby doses to higher doses, and there are extended intervals of biweekly dosing, and we are seeing some studies that are suggesting you can go to even a monthly dosing if patients are having a nice response. Because, right, Donna, these drugs last for a long time.
And we're not compromising response by doing less frequent dosing.
Yeah, so a low dose is better than no dose of a lot of these drugs for our patients. And if he's responding, then you can definitely cut back. As we mentioned just in our workshop discussion, skin-related events can happen in 70%. So let patients know that their skins might slough off on their hands and feet, that desquamation, once it comes off, and they have baby skin, right? I do aggressive hand lotion, lac hydrin lotions. There's a lot of inexpensive over-the-counters. For the nail-related events, I use a lot of the nail hardener nail polish. You can see the patients will come in with the Band-Aids over their nails because it gets stuck on their hands and their skin, their clothes, and it can be very uncomfortable, but it's mostly just cosmetic. And so dysgeusia, which is the taste changes, is loss of taste. So sometimes I'll recommend with Palmet, we use dronabinol, which is like an older kind of a drug that we use for other chemotherapy-induced things. Some institutions do dexamethasone rinses. Donna, what do you find is helpful for oral toxicity?
It's challenging, and I don't think we have one intervention that's going to work for everyone. We've been trying dexamethasone, swish and spit. We've been trying icing, but there is an ongoing clinical trial right now looking at several interventions for oral toxicity. Yeah. So that's forthcoming.
Yeah, talisman. And then the CRS and infections are listed here as well. So again, disease monitoring, making sure the drugs are working with the CBC, chem panel, SPEP, light chains. And then also there's the transaminitis. You can see sometimes elevated liver enzymes, so be unaware for that. Now he has high-risk myeloma. This is step 10. Remember it was 10 steps? This is the last one. Yay! So he presents with high-risk myeloma. He's 77 years old, performance status of 2. There's the treatment history, same treatment history, little different scenario. Is there a trial of a novel bispecific antibody that he might be a candidate for? Do you think of anything else that's in the pipeline, Donna or Charisse, that he would be a candidate for.
So possibly cevostamab, which has a different target. And there's actually several bispecific antibodies currently under investigation.
We'll talk about two of them in a moment.
Yep.
And then what about clinical trial involvement? I think that there's so many myths associated with it. There's a bias on our part as providers. We think, oh, they're not going to want to drive there. They're not going to want to go through that. But there's this ACCC Just Ask campaign. Like, just ask them. And so you might be an infusion nurse or a bedside nurse or just a friend of somebody. Just say, hey, maybe you want to consider a clinical trial. It used to be a last-ditch effort, but not anymore. We have clinical trials in MGUS and smoldering myeloma. So just asking your patient. HealthTree Foundation has lots of resources on their website as well. You can reach out to them. But it's so much better than it used to be. You get so many resources for many clinical trials. In assuming he receives Linvo, what I'm going to.
I know. I'll realize that later.
It's a bispecific antibody. It's a clinical trial. How should nurses counsel him on practical aspects of therapy? Charisse?
Yeah, we have this trial. Yeah, this one's a little different. It's IV. The ramp up, because it's on a clinical trial, they are admitted to the hospital. So for 24 hours for the first 2 doses, which are a week apart. Interesting thing with this one, as you get further along, the frequency goes up. And I know you're going to talk about this, but then based on response, then you decide whether it's every other week or it can go to monthly. So a little bit different for this one, but definitely an option.
Yeah. So the emerging bispecifics, the two that I'd like to close out our discussion on this morning would be with Linvo or linvoseltamab and elnuctamab. As I showed you before about these, this is the immunoglobulin with the different variable regions and the binding sites. And just like with the picture before, we have the CD3 and the BCMA. This molecule is a BCMA and CD3 bispecific. And this is the one that Charisse was mentioning that has a little bit different dosing and step-up schedule. Elnuctamab is interesting because it has an extra 2. So you think of bispecific antibodies, 1, 2, but then it's got this extra little bivalent binder up here. And so it might be a little bit different mechanism of action. So BCMA to CD3. So again, these are all B-cell. Again, B-cell maturation antigen is expressed less, on the healthy cells and more on the cancerous cells, but it's a very nice target for myeloma because it's pretty effective. So the emerging BCMA Linvo linker, and then one study tested IV Linvo at the recommended dose of 200 milligrams in relapsed myeloma, and it was 117 patients. And the efficacy take-home is that it's highly effective. Overall response rate of 71% in this population in this clinical study at that dose. And Charisse kind of already told you, it's a 24-hour hospitalization. So the other bispecifics, it's like days 1, 4, 7, or 1, 4, and 8. You're in the hospital or you're closely monitored. This is a day 1 for 24 hours and then day 8 for 24 hours. And then the weeks 3 to 4, it's once a week, and then it goes less often every 2 weeks. And then if you've had a nice, very good partial remission, your M protein went down by 90%, you could go to every 4 weeks. Or if you didn't get that nice response, you'd stay on every 2 weeks. So it's personalizing the way that we're giving the drug. What's the safety? Again, we have the priming dose, the intermediate, and the full doses here. And the CRS, of course, most of it happened during the step-up period. Most of it was very low and manageable. In terms of infections, this is just highlighting the different infections that they had. Again, 73% of patients had infections in this cohort of patients. And we saw that they were over time, but I think less because we're giving it an alternate dosing schedule. So other safety considerations, again, the cytokine release, cough, diarrhea, all the usuals that you've seen in the other reported bispecifics as well. Linvo is now under priority review of the FDA, so you might see this in an infusion center near you sooner than later. Again, it's a 24-hour hospitalization on days 1 and day 8. It's not that step up for a week dosing like the others. Elnuctamab is active, it's sub-Q, and it's in refractory and relapsed patients. In this study, 78 patients were treated, and 96% were refractory to the last line of therapy, so they weren't responding anymore. Again, we need more drugs to help people. This is the one that had the 2 little binding BCMA sites. Nice overall response. We have days 1, 4, 8, 15, and 22 for the dosing, and then Q week, and then Q other week. So again, you can go to extended dosing eventually as you go on the cycles. So in summary, it's hard to have 4 key take-home points after you had all this great information, but I'd like to emphasize the importance of starting from the beginning talk. 4 drugs are better than 3 for most people. Use quads and those multi-drug regimens. That's going to get your deeper response, so you can hopefully only find 1 in a million plasma cells on that bone marrow biopsy, that MRD negative status, to keep you in remission longer. Unfortunately, people will relapse though, so early referral and partnership, communication of care between centers for CAR T-cell therapy, and bispecific should also be part of your treatment planning and counseling strategies. Not everybody can get a CAR T. They might not have a caregiver. And then in all cases, supportive care, bone health, infection health, immunizations, etc., all those core aspects of nursing practice. So I want to say thank you. We do have about 5 minutes for question and answer, and I have like 72 questions here. We might not get to all of them in 5 minutes, but let me just go through the top of them. Is there age restriction for CAR T? No. What centers?
We've done 82-year-old.
Yeah. So unlike transplant, there's not an upper limit of age.
Ooh, how do you assess for ICANN CRS in an already confused patient? Donna has done this before. Usually we try not to get them.
So you would want a baseline neuro assessment to be golden, like to be normal baseline.
Yeah. And Donna has this handwriting is critical. We didn't show that handwriting sample. I like that picture where a patient, even if in confused, you can still get a lot of them to do the mini mental status exam and the toxicity screening. But that's a challenging one. Can a bispecific be a bridging regimen?
Absolutely.
Absolutely. And if you're doing a BCMA CAR T, it might be better to do talquetamab with a different target. But then if they're doing really, really well, it's hard to want to stop that effective therapy to switch to CAR T because there's no guarantees in life. One of the questions we also have here is, could you collect T cells at initial diagnosis? And you can speak to that.
So the CARTITUDE-6 trial right now, it's all we are collecting T cells prior to starting the initial line of therapy. This is all under investigation. I don't think we have the mechanisms in place to collect and store because we might never use those T cells. So it's really to be determined if we're going to move CAR T to frontline and how we would collect and store.
And insurance companies, I think.
Yeah, they might be in storage for a while. So,
Are we still using venetoclax for translocation 1114? This is one of my favorite drugs. There was a Bellini study which had venetoclax dex and then against bortezomib dex, and it had, the study stopped because people had, inferior outcomes. But then they looked at the data. If you had a translocation 1114, you did awesome. And so now we started using it. But then that next trial, the Canova study, which just read out as a negative trial, that study compared venetoclax dex versus Pomdex, and nobody should be going against Pomdex in the first relapse setting. It would have been better if they did like DARA or something. So anyhow, the take-home point is we still think it has activity. We have BCL2 inhibitor, lisafticlax in amyloid and myeloma. We still have the DARA venetoclax studies, and there are still some people that are doing well on venetoclax. What is your thoughts?
Yeah, we still use it off-label.
Same.
Good. And then how closely should we monitor for infections with bispecific after the step-up period? It's ongoing.
Yeah, always.
Always. Does neurotoxicity always equal ICANS in all cases?
No, because a headache is a headache, but you need to do your ICE score. And the high-risk period for at least bispecifics is going to be during that step-up dose. But sometimes I see ICANS several months later. So if the patient is altered, do your assessment. It's possible that they're having a very delayed neurotoxicity, but it's usually going to follow that ICE scoring.
In a sustained complete response, do you stop the bispecific, and how long do you continue? We talked about the alternate doses. We're still figuring this out, right, Sherry?
Yeah, we're still figuring out the doses, and we're finding that they probably need less. And so, there's the recommendation, and then there's what we're doing. And so a lot of us are taking patients to monthly dosing and they're doing fine. We don't stop them.
Especially talquetamab when they're having such skin toxicities. They're not, this food tastes like cardboard, and we give them lozenges and rinses, and it's still hard to find the right thing. So that extended interval is what's really helping.
They get better.
So
better.
With a decrease in frequency, you'll see an improvement in a lot of the side effects, and the response. You're not jeopardizing response, which is great about these bispecifics.
Yes, if it's working, it will continue to work at a less often interval. So who is not a candidate for CAR T or bispecifics and vice versa? Who would you just say, like, you're never going to get a CAR T? We talked about Thomas, who was 77, didn't have a caregiver.
So caregiver, I think, is crucial for CAR T. Bispecifics are right off the shelf, and literally, I think anyone could be a candidate. CAR T, I think caregiver is going to be and the determining
fit enough to wait for that manufacturing. So finding that right bridging therapy, and we talked about selinexor. Now we're using that a lot more to help with the T-cell fitness. So which therapy is more suitable, cellular therapy versus bispecific, when thinking about the gray area patients who have worsening performance status but not like quite terribly bad?
So one of my physicians said, the CAR T is the Rolls Royce of therapies, and the bispecifics are Toyota Corollas. But Toyota Corollas is the most popular car in the world, and they're durable and good cars, right? So
exactly. So I think there's a home for all of these drugs. And again, Charisse and Donna and I have been doing this for over 10, 20 years, and we've seen such advancements. I can't wait to see 5 years from now what's going to be available. You can see on the iPad, I think I hit most of the important, because there were a lot of duplicates about the collecting CAR T cells. One of the end-of-life care discussions did come up in here. When does an end-of-life care discussion come up in myeloma? I think, unfortunately, we have these doctors that just want to keep treat. And as a nurse, I'll say, you know what, it's okay to say you don't want to get hospitalized again for another bispecific, and you're taking 7 days out of your life if you just failed teclistamab, and then you failed talquetamab. Now we're going to try to give you something else in a clinical trial. It's okay. How do you approach the palliative care, supportive care in your institutions?
So I literally got booed off the stage because I'm at a large academic center. It's not a topic that comes up frequently. We don't want to give up. So I'm probably not the right person to ask, because I literally said that answer and people were not.
It's hard, right?
Yeah.
Because we always have had that one more thing. And so in my mind, if you don't start bringing it up, because they get more frail with all these lines of therapy, and you have to start introducing that concept of you're in control of this and you can stop, because we get to a period sometimes too where we're admitting them for chemotherapy to get control of their disease, and then going to another therapy, and it's hard for patients because and we talk about that next line of therapy, and they want to know what's next, and then suddenly there's nothing.
So
it's a hard place.
I think I'm so blessed. I work in an academic center that has social work, palliative care, and supportive care. And so we integrate those services early on. And so it doesn't have to be that treating physician, that treating provider, it's that team. So in calling on different people in your team to have those discussions, if you're not comfortable with it, I say we'd love for you to get all these lines of therapy, all these effective drugs. But if you have a high risk and you're relapsing rapidly, are you getting more side effects from the disease or the treatments? Quality of life is super important. So I think we're done. Good job, everybody. I'm so proud of all you that stayed. Thank you.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/FRR860. This activity is supported by educational grants from Bristol Myers Squibb, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, Regeneron Pharmaceuticals Incorporated, and Sanofi. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, HealthTree Foundation for Multiple Myeloma. Remember to download the slides and practice aids.